Hi, I'm Brennan Cavallo, and I'm going to talk to you about ultrasound-assisted neuraxial placement. I want to answer two specific questions. Why should we bother to do neuraxial ultrasound, and how do we do it? Now, when you do an epidural or spinal, essentially it's a blind procedure and you have no information prior to sticking a needle in. By doing a pre-procedure ultrasound, you can reliably establish midline, a good estimated depth to the epidural or the spinal space, an accurate interspace identification. You can also determine the optimal interspace and insertion point and the angle that you need to put the needle in to optimize insertion. Now, we have fairly good data suggesting that depth estimation to epidural space is very accurate when you use ultrasound. Meta-analysis data suggests a very high correlation, near perfect, of the relative depths, and the studies vary from 0 to 8 millimeter difference between ultrasound measured and actual loss resistance depth. So we have level 1 evidence for this. It is important when you are measuring to account for the angulation of the TUI needle and releasing probe pressure, which is particularly important in obese patients, as you may increase the 95% agreement limits for depth estimation. But either way, it's going to give you within a centimeter an idea of when you get loss resistance. Now, it allows you to accurately determine interspace. If you rely on palpation techniques, you are correct only a third of the time, and you generally are 1 or 2 interspaces higher than you should be. And it's because the Taffier's line that we use is not very accurate in determining the interspace L45, and therefore we generally go higher than we should, which could decrease the safety of a neuraxial technique if you're trying to go in the lumbar space below the conus. It also allows you to determine the optimal interspace. This is a slide from a study looking at which is the best interspace to go into and the changes during pregnancy. In this study, they found L23 being easier than L3445 based on a larger visible dura and a shallower depth. In a different study that used MRI to look at optimal windows, similarly determined that the higher lumbar interspaces are generally easier, but you'll notice from the figure that there's huge variation in the individual windows that different interspaces present, suggesting again that real-time measurements with ultrasound to determine the optimal space in that individual patient is the best way to go. But generally, the higher lumbar interspaces are easier than the lower ones. Does it improve your ability to insert? And data would suggest yes, you can almost halve your technical failures, you decrease your needle redirects and improve first pass success, and you can decrease the procedure-based time. Obviously there's time to make the markings prior to the actual procedure, but these offset each other. So good data again in the form of level 1 evidence in meta-analysis. There is weaker evidence in cohort studies showing you get subsequent improved block successes, both with improved analgesia and higher satisfaction, at least in the obstetric literature. And we suggest that this may be because of preferable midline placement or optimal interspace selection. Again, I showed you we tend to go too high, and high interspaces may not work as well, especially in second stage labor, for example. But determining the optimal interspace will clearly improve your ability to provide surgical anesthesia around the area that you require. There is some data suggesting it may improve safety, not as strong level 3 evidence, but there is data suggesting you get decreased traumatic procedures, so less heme on your TUI or spinal needle, a trend towards less backache, probably because of less needle insertions and more midline placement, therefore through less musculature. No data yet that it decreases unintended dural punctures. There is theoretical advantages in identifying the correct interspace. We will less likely go in interspace higher than we need to, where conus may be included in our placement, especially when we're doing high lumbar, when we really want to go lower lumbar. And because of less traumatic or less needle passes, less likely to cause injury. And this has been associated with higher neurological injuries with the number of needle passes. Now, obviously, in patients with skinny backs, it's a lot easier to do neuraxial placement, but in patients with higher BMI or back surgery, it can be significantly more difficult, and this is where neuraxial ultrasound can help significantly. It's estimated that about 4% of blocks are difficult, and with more difficult block placements, you have increased complications. One study showing a 19% increase of an accidental dural puncture with each centimeter deeper. You get loss of resistance for epidural placement. So does it really help in the difficult patients? So this is an excellent study that looked at patients who were either obese, scoliosis, or previous back surgery. Orthopedic spinal anesthesia procedures were being done. And across the board, with a number of providers comparing in a randomized fashion ultrasound versus palpations, doubled first pass success, halved the number of needle passes required, quicker to placement and finding the site of insertion. And yes, it did take longer to measure your landmarks prior to the procedure, but all round providing good data suggesting in difficult placements neuraxial ultrasound is worthwhile. So that's the data for its utility, pre-procedure ultrasound. So let's run through quickly how to do it. It's actually an extremely simple procedure, and the learning curve is actually estimated to be quicker and easier than traditional landmark blind procedures. And this is a study in the obstetric literature showing very high success rates early on, even at around 10 attempts in the black line of mean ultrasound guidance versus the traditional means of palpation, which had a longer number of times to get to proficiency, estimated to be around 30 to 50 procedures. There's a lot of equipment available. Most important thing is that you're using a curvilinear probe with enough penetration. There are other probes that you can use, but this is my preferred probe. And generally bone is viewed as an enemy of ultrasound, but in this case we're using it specifically, and it's the artifacts that they create that we use as pattern recognition to estimate where we need to go. We're using bony landmarks, specifically spinous process, laminar and transverse processes, and then posterior and anterior complex. The posterior complex is made up of the ligamentum flavum and posterior dura, and the anterior complex is essentially the vertebral body with the ligamental attachments along the back of it. And I'll show you ultrasound images of these as we go along. So it's all just about pattern recognition, like I mentioned, using 2D or B mode ultrasound, looking for bone and soft tissue, and various patterns that have been described and names put on them, and we'll run through these. So the first thing is you hold your probe parasagittal oblique, and with this near vertical placement of the probe, you're counting up from the sacrum your interspaces, and the key is you want a nice sawtooth pattern formed by the laminae, and you count up the interspaces, making sure you have your vertebral bodies in view and are able to count up the interspaces. You'll see the probe is slightly off midline and angled in to try and get a perfect image of the midline, so parasagittal oblique approach. Then you flip your probe horizontally. If you flip on the spinous process, you get what is called a cone sign, or often described as a shadow of a man with a coat. You can see it kind of reflecting down. The reason for the shadow is the spinous process absorbing ultrasound and giving a nice acoustic shadow. And it's very characteristic when you see it. It's close to the probe, easy to determine. If the probe is then slid down and you get into an interspace, you get either what's called a bat's ears sign, the two little ears of the bats being formed by the articular processes and the shadow behind them. Others have described this as the equal sign being the ligamentum flavum as the posterior complex, and the anterior complex, as I mentioned earlier, being the vertebral bodies with the ligamental attachments. You'll also notice from this image that the transverse processes are a surrogate for where your ligamentum flavum and dura should be. So if you struggle to see the equal sign, you can make an estimation with this. So I want to show a real-time example. There's your BATSI as an equal sign at interspace, onto a spinous process, nice cone sign, and then back to another interspace, adjusting accordingly. And once you've seen a few of these, it's extremely quickly and easy to do. You can do a neuraxial ultrasound in a couple of seconds and a push, especially if you're not caring about counting up the interspaces, but just determining midline and which interspace to go for. You then are going to measure it by convention the inside of your posterior complex. A lot of machines will automatically give you the markings, or you have to go from skin there and do a quick measurement. Remember to release pressure if you're applying a lot of pressure on the probe, and account for some angulation of the needle relative to the ultrasound when doing the actual procedure. You then mark it off. Remember, it's a pre-procedure marking. You use a marker pen. There's different techniques described. You can do an indentation instead of marking with a marker. And also appreciate that when you're marking laterally to the right of the probe, you can see it's the narrow part of the probe. It can be difficult to get the exact measurements, so some recommend flipping the probe and getting a more accurate mid-interspace measurement for the markings on the right or the left. And remember, when you're cleaning off the back, not to rub too hard and wipe your markings off. Now that's in the normal weight individual. It's very easy to see nice imagery. In the obese patient, it can be particularly difficult to get a good image, and it often leads people to lose faith in the ultrasound for this population. I think the key to success is set your expectations before you start. So you're not going to see this beautiful image, but you will always see spinous process. It's close to the ultrasound beam, and you will almost always see it and have an ability to know where midline is, see one interspace, find the next interspace, and between those two you should be finding your interspace. So two spinous processes and interspace in between. You can use the parasagittal view to try and get an acoustic window. The depth measurements are very close to the horizontal view. And equally, you can use your transverse processes, like I mentioned, as a surrogate to indicate where you would expect loss resistance. And transverse processes are easier to see often than the equal sign. So a combination of spinous processes and in between those for depth using your transverse processes almost always gives you very valuable information in the obese patient, i.e. where is midline and how deep do I need to go, with the expectation of maybe preparing a longer 2E needle if needed. Alright, so that's pre-procedure ultrasound. As we move to the future, are we going to have other abilities with the ultrasound in the neuraxial space? So the first one is the ability to determine the catheter better. And there is some data, not great, of getting images for reliable placement. This is a study from TEE during surgery with a thoracic epidural, and they noticed with patients that were getting more spread posteriorly compared to lateral, had less pain in recovery, suggesting you may be able to test the efficacy of your thoracic epidural using TEE. Now clearly that's not that useful for lumbar epidurals, but there is some data where ultrasound using both color Doppler and M mode was somewhat useful, 68 to 75% ability to detect where your catheter tip was, and certainly more effective of actually showing some saline injection and movement of saline when injecting and looking for the Doppler signal pathway. So my suggestion is this is something that can be attempted, but at this stage and with the technology we have, not perfect, but something that is an option. Now, I've been discussing pre-procedure, but what about real-time scanning? And there's several reports of successful utilization and even randomized controlled studies showing real-time placement, single providers, expert providers doing this, and reducing first attempts, less needle passes, and shorter time. And there's various descriptions of the best technique to use. The problem with this is it's limited to expert providers, and it's very successful in normal weight individuals. But this is not the ones we struggle with spinals and epidurals. So how does real-time scanning work in those individuals? And the data would suggest not very well. This is one study that I show with the ultrasound group on the right. Twice as many procedural difficulties, a lot more needle insertions. So very disappointing in the patients that we most needed to assist us in. And this is an obstetric study of obese patients, just a small cohort of 10 patients, but only 6 out of 10 could even see the 2E needle, and the tip of the catheter only identified in one. So they were able to insert in all 10, but it didn't seem to really help them that much. And I think until technology improves sufficiently, real-time ultrasound might be more hassle than it's worth. And the big concern is, while searching for your 2E needle, you can accidentally wet tap a patient. So I don't think it's ready for prime time in the patients we need it in. All right, so in summary, I think it's an essential tool to learn. We don't let any of our residents go through the obstetric anesthesia rotation without having some skill set in doing a neuraxial ultrasound. It's an important technique to learn. It's an easy technique to learn. It certainly helps you in the difficult patient, the obese patient, difficult palpation, patient with scoliosis or spinal deformities. It can be useful in screening patients who give a previous history of difficult or failed neuraxial blocks. And it's certainly a great teaching tool that really teaches you anatomy of the spine, which can improve your subsequent standard palpation techniques and make you think a little bit more about how to redirect your needle when you hit bone. I do think it'll eventually move towards real-time ultrasound guided placements, but at this point, for me, it's pre-procedure markings, and it's been a big help and certainly reduced my difficult neuraxial placements. So thank you very much, and look forward to chatting more about this.